So thank you very much for joining us today at this module on basic hemodynamic monitoring. This lecture will focus solely on cardiovascular function, where we will be going through the basic function of the heart and the circulatory system and how to evaluate it. I have two conflicts of interest to declare. So the two main objectives for this lecture are to identify the main functions of the cardiovascular system. I will make a quick mention of receptor physiology, as these have direct relevance to some of the most commonly used therapies in intensive care. I will also explain the concepts of preload, afterload, and contractility, and how they are assessed clinically. So, the cardiovascular system is commonly thought of as a pump, with the left heart pumping oxygenated blood out to the aorta and the large vessels here. This is what we call the macrocirculation. The blood then reaches this fine capillary network where oxygen is downloaded to the tissues. The microcirculation will not be considered in today's lecture. Now, after this capillary network, deoxygenated blood is carried in the venous system back through the inferior and superior vena cava to the right heart, where it is pumped out through the pulmonary arteries into the lungs, where they are oxygenated again and the cycle starts again. So the heart cycle is divided into two phases, as you all know. Systole, which is an active and energy-dependent phase, and diastole. So the left ventricle ejects blood into the aorta, as I showed you in the previous slide, and the right ventricle ejects blood into the pulmonary trunk and from there on to the lungs. That was systole. The second phase is diastole. Now, although this is traditionally seen as a passive filling phase where the ventricles are filled, this phase is actually very important for myocardial relaxation. And evidence now supports the importance of lusitropy. Lusitropy meaning ventricular relaxation for the development of heart failure, including that seen in the critically ill. So in diastole, there is not only just a passive inflow of blood from the atria to the ventricles, but there is also a final active atrial kick where atrial contraction causes the ventricles to fill right up. And this is important because it is lost during arrhythmias, such as atrial fibrillation, that is commonly seen in critically ill patients and that can contribute to cardiovascular insufficiency. So, the main function of the heart is to pump blood. It pumps blood out to the circulatory system and to the organs. And the amount of blood that is ejected by the ventricles with each beat is called the stroke volume, SV. And the stroke volume times the heart rate is the cardiac output. So cardiac output is the volume of blood pumped out by the heart every minute into the aorta. Now, stroke volume may be decreased for various reasons, for example, in hypovolemia. So when this happens, the heart can compensate by increasing the heart rate here to maintain cardiac output. Sometimes there is also an increased demand for cardiac output. So examples of these would be, for example, during exercise, during mobilization, or during fever. So in these cases, heart rate also increases to maintain cardiac output. The other way to increase cardiac output, of course, apart from heart rate, is to increase the stroke volume. And here I want to talk about three main concepts, and that is preload, afterload, and contractility, the three major determinants of stroke volume. So preload is the stretch of myocardial fibers before contraction, as seen in these diagrams here. So this is before they're stretched, and this is when the myocardial fibers are actively stretched and pulled apart. The more stretched they are, the more volume you will get. So this, on the x-axis, the left ventricular end diastolic volume, is a measurement of ventricular stretch, and on the y-axis, stroke volume or cardiac output. So the more stretch, the more increased preload, the higher the stroke volume. But you will see that the relationship in this red line here is not linear. It is not a straight line. So you want to think about it as blowing a balloon. In the beginning, you need to stretch the balloon a lot before you get any volume. And then it becomes relatively easy in this steep part of the curve. And finally, when the balloon is maximally stretched, not much more volume is gained. And this is what we call the Frank-Starling relationship. So how is preload assessed clinically? Well, it's not exactly possible to assess the stretch of the myocardial fibers, and instead one measures a surrogate, and that is that left ventricular end diastolic volume, for example, using echocardiography. And critical care physicians over the years have also used surrogates such as the pulmonary capillary wedge pressure, which is obtained when you have a Swan-Ganz catheter, or a central venous pressure that you get from a central venous line. However, there is clear evidence now to show that these are very poor indicators of preload, so these should no longer be considered surrogates for preload. So in fact, although preload is an important determinant of cardiac output, it is very difficult to assess clinically. And one method is not to assess preload directly, but to assess the response to preload. And these are sometimes called dynamic measures. So the currently recommended way of assessing dynamic preload response is the PLR test, the passive leg raising test. This assesses whether the cardiac output will increase in response to a bolus of fluid, except you don't give a bolus of fluid. You do this instead. So the PLR test is easy to do, but it is not just a matter of raising the patient's legs. This is a very common misconception. This is how a passive leg raising test should be done. So critically ill patients are most often cared for in the 45-degree position. Now, this may not be the case in COVID care where many patients are prone, but for those who are in the 45-degree position, what you would need to do is a series of steps. Firstly, you need to put the head down, lie the patient flat, and then very quickly raise their legs to 45 degrees. This, in effect, gives the patient an auto-transfusion of about 150 to 300 milliliters of blood and is completely reversible, so you don't need to give fluids. And this is obviously an advantage over giving patients a fluid bolus that you can't take away later. And this is, of course, of particular importance in patients with lung disease, where you want to avoid over-resuscitation with fluids because that can cause fluid overload and lung congestion. So the passive leg raising test requires, however, that the patient already has an arterial line, because you need to measure the cardiac output before the test and after the test. And a change of more than 10% in stroke volume or stroke volume variation is considered a positive test. So a positive PLR test indicates that the patient is fluid responsive. So preload is manipulated by giving the patient a fluid bolus. If the patient is hypotensive, low blood pressure, and the doctor is considering giving the patient fluids, but you're not sure whether or not the patients will respond, this is one way to test whether or not patients will benefit or will increase their cardiac output in response to a fluid bolus. So the positive PLR test indicates that a patient is preload responsive. So now afterload. Afterload is the load against which the heart has to contract. Now, normally, it's measured as ventricular wall stress. But wall stress is extremely difficult to measure in the clinical setting. Thus, we use systemic vascular resistance as a surrogate. And this also requires an arterial line. Now, afterload is easily manipulated by giving the patient vasoactive drugs. So this would be vasopressors, such as noradrenaline infusion, or vasodilators, such as nitroglycerin. So calculation of the SVR, or systemic vascular resistance, is very easy. It's just calculated from the Ohm's law. Now, Ohm's law states that resistance is the pressure divided by the flow. Now, this is the reason why you require an arterial line, because you need to know. So this is just a normal output. You might not have the screen in your department, but this is just a normal screen that most people have in their ICUs. So using an arterial line, you will have continuous arterial blood pressure measurements. And then using some of the commercially available algorithms, you will also have cardiac output. The change in pressure, defined as the MAP, mean arterial pressure, minus the CVP, divided by the cardiac output, will give you the systemic vascular resistance. So it's very easy to calculate. So that was SVR. Now, the final determinant of stroke volume is myocardial contractility. So contractility is the strength of the muscle contraction that is independent of preload. So here you see the Frank-Starling curve again with the stretch, left ventricular end diastolic volume on the x-axis and the stroke volume or cardiac output on the y-axis. And you will remember that increasing preload will increase contractility up to a certain limit. So that is the effect of preload. But the effect of afterload, contractility is not to just move contractility up this line here, but to shift the whole curve upwards and to the left. So for any degree of stretch, you will have a larger cardiac output. So this is the effect of contractility, and this is manipulated by giving inotropic drugs such as dobutamine. So the most common way of assessing contractility in the ICU is using echocardiography. Now here you will see two very different hearts. The first one is one with very good contractility. This is the left ventricle, right atrium, left atrium, and you will see how the muscles are squeezed together to eject the stroke volume. Whereas in this image, you will see a poorly contractile heart. The muscles are not really squeezed together, so the stroke volume is low. So a logical question is, why focus on the cardiac output? Well, the easy answer is that it is a major determinant of tissue oxygen delivery, DO2. And the DO2 is equal to the content of oxygen in the arteries times the cardiac output. So the content of oxygen is in turn determined by hemoglobin and the saturation of O2 in the arteries, plus a small component that is dissolved in the blood. This is negligible. So once you have corrected for hemoglobin and saturation, say with mechanical ventilation, the easiest way to manipulate DO2 is by manipulating the cardiac output. And this can be done quickly and effectively. So I've talked before about cardiac output and the influence of preload, afterload, and contractility. And the adrenergic receptors are central in their regulation, and they are also the target of many of the drugs that you may be using or will be asked to give in intensive care. Now, the adrenergic receptors are classified into the alpha and the beta receptors. And then they are further subclassified into alpha 1, 2 and beta 1, 2 receptors. So in the heart, beta 1 and 2 receptors dominate. Stimulation of beta 1 receptors cause an increase in heart rate and contractility, whereas stimulation of beta 2 receptors will cause vasodilatation, decreased peripheral resistance, so decreased afterload, and a whole host of other effects on the smooth muscle. Whereas stimulation of the alpha 1 receptors, for example using noradrenaline, will cause a vasoconstriction and increase in peripheral vascular resistance with an accompanying rise in blood pressure. So in clinical practice, one would use agents such as adrenaline or dobutamine to stimulate the beta 1 receptors. And what that does is to increase contractility, increase the force of myocardial contraction. However, remember that these agents also have side effects, one of which is arrhythmias. And in fact, rhythm disturbances may be so severe that the drug has to be discontinued. Agents such as noradrenaline or phenylephrine act on the alpha 1 receptors instead, and stimulation will cause a constriction of the blood vessels, giving rise to an increased cardiac output. However, these agents should also be used with caution, since the administration of potent vasoconstrictors in under-resuscitated patients, so hypovolemic patients, will cause hypoperfusion. It is also useful to remember that many agents act on multiple receptors. So dobutamine, for example, has both beta as well as alpha effects, but the beta effects predominate. So instead of thinking about receptor physiology, it may be useful instead to think of the clinical effects of these drugs. So we know that adrenaline, which is a classical resuscitation drug, will increase contractility, so inotropy. It will increase the heart rate, and it is also a potent alpha 1 receptor agonist, so it will increase the systemic vascular resistance. Whereas noradrenaline has predominant alpha 1 effects, so will increase the systemic vascular resistance, but has lesser effects, say, on myocardial contractility. Dobutamine has predominant beta 1 effects, so mainly effects on contractility and less effects on heart rate, and actually causes a decrease in systemic vascular resistance, and so on. So just a quick word about arrhythmias. Critically ill patients have an increased risk of arrhythmias for many reasons. Firstly, they experience large fluid shifts with electrolyte imbalances that affect the interstitial milieu, and they may in itself be arrhythmogenic. Many drugs that you will be using in critical care also affect the electrical activity of the heart, and this can include very common drugs such as antibiotics. Azithromycin and levofloxacin are drugs that you will be using in COVID care. Hydroxychloroquine is another example, and neuroleptic drugs. But even the inotropic drugs themselves, such as dobutamine, can induce such severe arrhythmias that they negate any possible benefit on cardiac output. And then don't forget that many of the drugs also have interactions. And finally, organ failure that is common in intensive care patients will cause decreased clearance of some drugs, causing accumulation and potential cardiotoxicity. So arrhythmias are better prevented rather than cured, and this requires pharmacovigilance. Many units have pharmacists that can advise on the best combination of drugs or their alternatives. So avoid cardiotoxic drugs or combinations that can be deleterious. And don't forget the common things, such as avoiding large fluid shifts and correcting electrolyte imbalances. Hypo and hyperkalemia are common in intensive care, and both cause problems with the regulation of heart rhythm. Easily forgotten electrolytes such as magnesium are lost through large diuresis, continuous renal replacement therapy or dialysis, and may be easily replaced. And magnesium in particular is a membrane stabilizer. So the heart and the lungs are actually connected in series. They are not independent of each other. So both are dependent on each other. Putting a patient on mechanical ventilation with high positive airway pressures may actually compromise the circulation by increasing intrathoracic pressure. And the increase in intrathoracic pressure then reduces preload by impairing venous return to the right heart. In the very worst cases, this may actually lead to a condition called acute cor pulmonale, which is a medical emergency. So in summary, the heart and the circulatory system act as one to ensure tissue oxygen delivery. Cardiac output is amenable to quick manipulation, which is why we monitor it. And cardiac output is manipulated by changing preload, afterload, and contractility. Preload is manipulable by giving or removing fluids, and you assess it using a dynamic parameter such as passive leg raising. Afterload is manipulated by giving vasoactive drugs, for example, vasopressors such as noradrenaline, and contractility is manipulable by giving inotropes. Don't forget that regular ICU interventions, such as mechanical ventilation, some of the drugs that you give and the fluids that you give have significant unintended effects on the cardiovascular system. The ICU patient has very little reserve and often compromised organ function that makes monitoring essential. So I hope that this helps you understand cardiovascular physiology a little better. Thank you for listening, and good luck in all that you do.